Sangeeta Rawat not joining? Should I invited president, no? मेरे को बोलना था. I would have got her.
Asmita ma'am, Ellen sir said he's unable to join because of the link. There is some problem in that he asked to resend the link, ma'am.
Okay, I sent him the link. Sir, the room is open, so we are audible and visible to the attendees. Sir, I resent him the link.
Okay, ma'am. Still says the attendees are in the waiting room.
Go on. If Dr. Palande is late, then you can introduce the speakers.
Sir?
Dr. Palande is late, you can introduce the speakers.
Okay, sir.
We shall start, sir. It's 5 minutes past 4.
Yeah.
Please start.
Good afternoon, everybody. I welcome you on behalf of both IFNR and Indian Academy of Neurology to the World Stroke Day webinar. As you all know that stroke is the third most common cause of death and fourth most common cause of disability. Though in spite of availability of acute thrombolysis and mechanical thrombectomy, there are many patients who are still with disability, and therefore the rehabilitation in stroke is something which is very, very important. And I want to congratulate both Abhishek and Guhan to bring the stroke rehabilitation on this platform to make the people understand that how rehabilitation can change their life in spite of a disability acutely got it. So with that note, I hand over to the chairperson, Dr. Deepak Palande, and convener, Dr. Guhan Ramamurthy.
Sir, thank you very much for the warm introduction, sir. So on behalf of the Neurorehab subsection of the IAN and on behalf of IFNR, and I welcome everyone to this World Stroke Day Symposium. So it's just to remind us all that the stroke recovery includes rehabilitation, and stroke recovery is not just about regaining movement. It also involves rekindling hope, rediscovering independence, and restoring the lives of the patient. And rehabilitation is the bridge that takes them from despair to determination, from fragility to strength, reminding us that every step forward, no matter how small, is a triumph of resilience. And this year themes reminds us that stroke is a global challenge with deeply personal impacts on patients, families, and caregivers. Rehabilitation offers a powerful avenue to support these individuals, helping to regain function, confidence, and independence. Yet, despite its transformative potential, access to quality care in rehabilitation remains uneven across the country and the globe. And in today's symposium, we will delve into the range of topics to bridge this gap, from the latest advances in high-intensity protocols, the robotics, the artificial intelligence, the virtual reality, and the most important aspect, the low-cost rehabilitation strategies. And our esteemed panel of experts will share insights, evidence-based practices, and cutting-edge research that are shaping the future of stroke recovery. As we begin, I would like to extend our gratitude to the esteemed chair, the faculties, the panelists, and participants who have joined us to make this event impactful. Your dedication to improving the lives of stroke survivors is always truly inspiring, and our discussion today will pave the way for meaningful advancements in stroke rehabilitation. And it is my great pleasure and honor to introduce my mentor, Dr. Nirmal Surya, sir. He is a man who needs no introduction in the realm of neurology and neurorehabilitation across the globe. But for the records, he is the associate professor at Bombay Hospital and Medical Research Center. He is the chairman of Surya Neuro Center, and his achievements are numerous. He is the Secretary General of the World Federation of Neurorehabilitation, President of the Asia, Ocean, and Society of Neurorehabilitation, and he is also the President of Indian Federation of Neurorehabilitation, past President of Indian Academy of Neurology. And it's also a happy moment for me to share that he has been elected as the chair of the rehabilitation at the IFBAS. And it is with great honor that I share this happy news with everyone on this occasion. And he is also the recipient of the prestigious award, the Kenneth M. Viste Jr. Advocate of the Patient of the Year Award and Mahatma Award winner. And this introduction runs for several pages. And we welcome you, sir.
Thank you, Guhan. Yeah.
Thank you,
Go
sir.
ahead.
And to introduce the chair of the Neurorehab subsection and the secretary of the Indian Federation of Neurorehabilitation, the brain behind rehabilitation, the development of neurorehabilitation. And he is the neurorehab specialist and director at Center of Rehabilitation for Kokilab and Dhirubhai Ambani Hospitals. And he has numerous achievements, and which includes Dr. Anusia Vasant Award, member at large for Presidium World Federation of Neurorehabilitation. And he's also elected as a member the recent convened meeting for the rehabilitation division of the IHBAS. And is the chair of the multiple sclerosis SIG at the World Federation of Neurorehabilitation. He is the chair of member at large at the WFNR as well. And he is the chair of the Neurorehab subsection of the Indian Academy of Neurology and secretary of IFNR. He has edited several books and several book chapters and over 100 research papers and over 300 invited lectures in neurosciences and rehabilitation. And he's also back from US, fresh for another meeting today. We welcome you, sir. We welcome the chair for this symposium today, Dr. Deepak Palande, sir, who is a former HOD and professor of neurosurgery at Sir J.J. Hospital, Mumbai, Maharashtra. And he is also the director at Indian Federation of Neurorehabilitation. He has several areas of interest, and prominent among them is neurorehabilitation, and he is a prominent figure in the realm of rehabilitation as well. We welcome you, sir. A warm welcome to you, sir. Next slide, ma'am. Next slide, ma'am. So going to the introduction of speakers, it's really a great honor for me to introduce my guru, Dr. Lakshmi Narasimhan, sir, and it's a special moment to have my guru and my mentor on the same platform today. Dr. Lakshmi Narasimhan Ranganathan, sir, is the former director of neurology at Madras Medical College and is currently the head of the Department of Neurology in Sri Ramachandra Institute of Higher Education and Research. And he's also, his achievements runs for several pages, and it's very hard to summarize it here today. But the prominent ones are Palatuxi Award and A.B. Baker Award, both of them from the American Academy of Neurology. He has delivered several memorial orations, including the orations, including the Dr. Devasagaya Memorial Oration. And he is currently elected as the president-elect of Indian Academy of Neurology. And it is a great happiness and honor to share this news with everyone. We welcome you, sir.
Thank you, Glenn. Thank you.
Thank you, sir. Next, Dr. Navita Vyas, ma'am, the first certified pain sonologist in India. And it's a great privilege to have ma'am in this platform to learn from ma'am about the pain. And she's a consultant on rehabilitation medicine, pain and palliative medicine at the Kokilab and Dhirubhai Ambani Hospital. She's a program head for fellowship and interventional pain management, where I was a student, and it was a wonderful learning session for me. And she is the past secretary of IAPMR, founder member of IFNR, and she has several publications, more than 30, and has crossed several numbers beyond that. And she is the first women CIPS in India, Best Paper Award in GIPS, awarded Best Doctor in the field of pain medicine in Outlook magazine, and awarded Best Women Doctor in field of pain medicine last 2 years on the Women's Day. And as she wields the wand of ultrasound, every pain in this world would melt away. Thank you, ma'am, for joining us on this webinar.
Thanks, Kumar.
Welcome you, ma'am. And last but not the least, the most important is the communication and the language. And we have the specialist for the speech and language pathologist, Dr. Zainab Nagri. She's a consultant speech and language and swallowing therapist, Bombay Hospital, Voice and Swallowing Center, Mumbai. And she has bachelor's and master's of audiology and speech language pathology. Her area of specialization is neurorehabilitation, focus on dysphasia, aphasia, and cognitive linguistic disorders. She is a gold medalist at the final bachelor's and master's examination, Best Speech Paper Award, Dr. M.V. Kirtan Poster Award, and she is chair in the organizing committee of ISHA-CON, ISHA representative at WFNR, scientific committee member for Society of Feeding and Swallowing Disorders, delivered talks on dysphagia and voice disorders at various state, national, and international level conferences. We welcome you, ma'am. So with this introduction about our elite panelist, we will move to the talks on stroke rehabilitation. First, may I invite Dr. Nirmal Surya, sir, for a short introduction about this symposium and to deliver the talk on the changing landscape and low-cost approaches in neurorehabilitation. Sir, your mic is muted, sir.
Give me one moment. Let me share the.
Can you please send the YouTube link also?
Yes, sir, I'm sending.
Okay. Are you able to see my screen?
Yes, sir.
Make it full screen. So how the things are changing and what could be the approach when we are living in a country like India and other low middle income countries where the cost is a challenge. So I will talk in a couple of pattern, and one of them would be introduction of this, then challenges in providing neuro rehab services in particularly country like India, and what are the strategies which to improve the neuro rehab in these countries. So you know that disability is loss of function capacity due to the impairment resulting in inability to perform some activities for a normal human being. And people living with disability are more vulnerable compared to the general population. They have a poor quality of life, self-perceived quality of care and support. And rehabilitation services are extremely wrongly perceived as last resort after the failure of therapeutic intervention are often neglected, which mindset of everybody, not only neurologists, patient, society has to change that rehab start on day one as soon as patient has a stroke or problem. The need for rehab service become even greater in neurological disorders, some of which are incurable and some of which are having permanent sequelae like a major stroke. And strengthening of neuro rehab services may be of paramount importance in ensuring quite access to the high quality healthcare services. So if we need 1 in 3 people would require rehab at some point in time, and I'm not talking alone of stroke, but I'm talking of everything which requires the neuro rehabilitation. And there is a need has increased 63% since 1990, which is 1.48 billion, and 2019 is 2.41 billion, and now it is 2.8 billion people requiring the this rehabilitation. And low income countries, low middle income countries, upper income countries, and high income countries, if you look at daily death incidences of neurological disorder by World Bank in 2006, according to GBD plus and GBD2 of various neurological disorder. And you could see that how the things are bad in LMIC as compared to the upper and middle income countries. There are conditions which are more demanding, the dementia, the Parkinson disease, epilepsy, MS, stroke, MND, etc. And if you look at daily, again, in further detail, the cerebrovascular stroke is, world is 788, but low income country goes to 662, low middle income 1061. And this is bothering, because if you look at the other disorders overall from the WHO, the lower middle income country and low income country has got severe neurological burden. Look at India, 1.42 billion. We are leader in the population. 70% still lives in rural area where agriculture is their life. Cities have modern amenities, private setup, villages have poor facilities, and they have to go to the primary health center or alternate medicine. There are 12.68 lakhs allopathic and 5.65 Ayush doctor with a ratio of 1:854. 32.64 nurses, which is ratio of 1.559. So we have 558 medical college with 83,275, and now it increased further to 1 lakh and 42,720 PG seats. There are physiotherapists and osteopaths who are widely available. Neuro rehab specialists are few, like Abhishek. Yoga, Ayurveda, Surya Namaskar remains one of the main rehab point for the Indian community. And the burden of neurological disorder across the state in India also varies from different, from non-communicable, communicable, and the injury related. Different part of the country has different burden, and therefore we may need to come out with a strategy to lead into this. And these are the non-communicable disorder, and again, there are various disorder. If you look at the stroke, which is much more common in India. And stroke again is the leader, particularly as the age advances, 60, 64, but start from 30 years, continue increasing till the 70 years, and then thereafter it reduces. So age group India, if you look at the stroke, it is disabling. There are neurologists, which are about 4,000. I'll come to that. These figures illustrate, again, demand and supply, if you see, and there's a huge unmet need for the quality neuro rehab services that exist among LMIC. And you can see that everywhere there is a deficit. 4,000 neurologists, nearly 1,250 PMR specialists, 75,000 physios, 30,000 OT, 45, around 50,000 speech and language, few hundred neuropsychologists. We don't have any idea about osteopath. We don't know if the rehab nurses are there or not. And you look at the WHO data of the rehab specialists in various parts of the world, and you look at the Asia, Southeast Asia is very low. Either it is the physical and rehab, medical rehab, or physio, or prosthetic and orthotic, or the occupation therapy. We really need to scale up and have more number of professionals available. Challenges in providing rehab services are from policy and planning to the laws, to the infrastructure, to the resources, poverty, stigma and culture, and main important thing is lack of awareness and education. So how do we overcome this? We need to have task shifting. So there can be task sharing, task shifting, which involve training non-specialist healthcare workers such as community health worker to provide basic rehab services. This can help to expand to reach the neuro rehab service in an area where there is a shortage of specialist healthcare professional. So you can have training phase, practice phase, and maintenance phase. And we need to have more of them to provide this. We need to look into the community-based rehabilitation, so that in the area where there are not many experts are available and many patients with common rehab problem could be treated with once the patient has been discharged from the hospital. And diseases like stroke, Parkinson disease can easily be treated. So community-based rehabilitation is one which can be a wonderful in absence of multidisciplinary rehab services in the community. But tertiary hospital care would be very important. Not many people would be able to afford. Then the family-based rehabilitation. For those who cannot travel to rehab unit, either because of time, distance, or the finance, or uncooperative patient, violent behavior, bedridden, family burden, old age, and therapy giver could be anybody. So family is the focal point. It helps in early diagnosis and treatment. It approaches on family base. Rehab is aimed at family. Stress is shared by the family, and they develop the skill and prepare to cope with long-term effect of neurological illness. Depression and anxiety of patient and caregiver can be reduced, and they can switch the role as per the required. So you have CBR versus FBR. CBR is ideal in rural area where communities are working together under the system of Panchayati Raj. Sarpanch is the head of community. He can be the focal point for the success of CBR. On the other hand, family-based rehabilitation could be useful in cities and metro where family is the focal point of rehab. And we need a bridge between the two in context of India to have a successful rehab program for all neurological disorder. And I always believe that family-based rehabilitation has to join with tele-rehab, and you could go through this article for that. So strengthening of tele-rehab in LMIC is what we are looking at. And COVID has changed completely. During the COVID, we realized that telemedicine worked. Before that, nobody was talking about the tele-rehab. And now 80% or more people are using the telemedicine. And this has become a reality because you have in a mobile, you have the data which is low cost, and you have a population who is wonderful. And tele-rehab can be worked out with this. We have the strength, opportunity, weakness, and the threat is, of course, the data. So we need to look at that. So one can develop the tele-neuro rehab academy. Stroke can be one of them, and you could have infrastructure building and national-wide environment training, telemedicine for doctor and allied stakeholder. We need to do collaboration with government, non-government organization, and others like those who are working in particular field, and involve the organization like WFNR, AOSNR, IFNR, IAN-IFNR to come together for the training, capacity building, advocacy, and guidance. Training and education is very important because you need to have various standardized program, assessment tool, communication between medical staff, tailoring for rural community, understanding the latest technology which you are going to talk about, working toward affordable healthcare, evidence-based practice, and working in a multidisciplinary team and exchange program with developing country. We need to invest in education and training, and we also need to address the socioeconomic factor which are the barrier for the dealing of the neuro rehab. One has to have a culturally sensitive approach, and data collection and research has to be secured. So this is how one can do the partnership with the leadership program by building up the proper rehab program. What is changes? The COVID has changed the education training, and you should see the practice. The community-based rehab to post-COVID has improved. The tele-rehab before pandemic was down. It has gone up in 2 years, and family-based rehab has gone up, and same is the tele-rehab. So tele-rehab and family-based rehab post-COVID has changed. And though community-based rehabilitation went down after the COVID, but has come back as a part of a rehab. These are some of the low-cost technology which has been developed in India, and they are useful for the robotic from Vellore. They have developed for the plug, that is a Pluto, which is a very low cost for the hand function. And these are some of the non-robotic company, again, being made by the CMC Vellore, could be useful. Computer game-based therapy is also been useful, and they are all low cost, which can be used in our country. Again, Dokas from Ludhiana has developed certain low-cost task specific for the hand So these are useful technology, though you will listen to the most advanced technology from the expert like Abhishek, Lakshmi, and Navita. So to conclude, the strengthening neuro rehab service in India and other LMIC at primary as well as district level for better function outcome and quality of life among patients living with neurological disorder in this country. To have a greater effect on population health, careful attention needs to be given to the system that deliver these services, training and skill of neuro rehab workforce, and monitoring of neuro rehab delivery to the client. Rehab play a critical role in optimizing health outcome. Advance in this field has been found lagging. Recognize neuro rehab contribution to improve functioning and quality of life among patients with disorder is fundamental in correcting. So, need of structural training in neuro rehab, tele rehab, and family-based rehabilitation are the most important, along with the collaboration with various organizations, could be the key for best possible rehab services in India. You can go through this article in Advances in Stroke Rehab for the more reading. Thank you very much.
Thank you very much for the wonderful lecture, sir. This went beyond just how to set up a low-cost rehabilitation, the various other opportunities that we need to keep looking for as a neuro rehab specialist, and how to set up low-cost rehabilitation in India, the importance of robotics that India has made it low-cost rehabilitation now. And with that, we will go to the next section, that is robotic rehabilitation. Robotics has been one term that has been fascinating in the current decade, and now in rehabilitation as well, and more so in stroke. To tell the why, when, and how, we have the expert in rehab robotics in India and across the globe, Dr. Abhishek Srivastava, sir. Over to you, sir, for the rehab robotics.
Thank you, Gohan. If you see scans like this, patient at 1 year lying somewhere in the bed in a vegetative state, the bed MCA stroke, ICS stenosis, or bed hemorrhagic stroke on the left side. Tell you in the end how they are at 6 months or 1 year post-stroke. So, can we change the brain is the biggest concept when studying medicine. The evidence to show that we can reperfuse the brain now with altiplase and tetratiplase to improve the tissue perfusion. What happens in first few months and first few years is brain recruit additional areas to perform new function, or some other part of brain takes over function. This ability of brain to change in response to a stimulus is called as neuroplasticity. So what we're doing in rehab is to actually remodel the neural circuits by two ways. One, by intensive training, with the help of robotics, which is called as experience-dependent plasticity, and second, new treatment like medications, neuromodulation, and HPOT. Today's talk is primarily on robotics. These are machines which will operate semi or fully autonomously to perform various functions which people with disability will not be able to do. People ask me this question, will robots be going to replace therapists in long term? No, that's never going to happen. You gain more strength or more new function, more new motor power in robotics, but to learn the function in conventional therapies. Both work synergistically. Both can never replace each other in long term. Different types of systems are available as per chronology, as per therapeutic assistive, only for upper limb, only for lower limb. Are they variable or are they fixed? Exoskeleton or endoskeleton based. For example, these are upper robotic systems, multiple types are available in upper limb also. These are exoskeleton, which arm goes into a device which can remove the exoskeleton, or end effector ways where you only are able to touch the or hold the arm part of that. There are hand and therapy robots, sensor-based machines, multiples are available. The most commonly used are the exoskeleton-based systems, where this arm is supported in a 3D working space. You're doing a task under training, like cutting an apple, driving a car in daily activity you do. You are self-initiating the movement. It's not passive training, this is active assistive training. God has made hand to use the hand, not to exercise primarily. So you're doing what you can do, what you can't, robot will sense, help you complete that task. So it is active assistive training, and you can get all the assessments every day, how much you can do, and you can plan the next therapy session. We call it Hand Studio. We have 3 systems. This is a army of power when there is no power in the upper limb, minimal trigger in shoulder. When you go to more power and shoulder, working on your forearm and elbow, you go to the army of spring, and this is Amidio, only for the hand, like the movements. That's how it works. You are an exoskeleton arm, it has a complete front of you. Cochrane review very rarely gives evidence in rehab, and they have shown that people who get post-stroke training on upper limb robotic systems have better arm function, better arm muscle strength, less dropout, and very rare side effects. So it actually works in the acute to subacute stage. For the lower limbs, the 5 basic type of technologies, the ankle-based system not used now, station trainer is not used now. Most commonly use these exo-based systems, footplate-based systems, or the overground gait trainers. This is the guy who was working his PhD in 1990. This is a real video actually. And in those days, there's a lot of concept of using body weight support system for spinal cord patients. On the same premise, they formed a company called Socoma and got this first device called as Locomat. This is the body weight support harness, which can offload the patient body weight. The robot will make you walk on a treadmill with a feedback, which can be augmented feedback, a 3D feedback, the strength you're doing, power in front of hip and knee in front of you. So you can reduce the body weight support as the patient is improving, reduce the robotic assistance, increase the speed, play more complex games. So first they've got a safe walk. Any person standing on tilt table with no blood pressure can be made to walk on the system, and then he can walk in the air, he walk on the treadmill. What is a nice walk? Happen in the first 12 sessions. And when they start walking, you can see their power generation in the hip and knee in front of you, virtually a game of virtual reality while on the computer. Very, very specific quality enhancement also. So in one session, a person actually walk up to 800 meters to 1 kilometer, which is 1,500 steps per day. Huge amount of exercise they can do in one session. So concept is with time, you reduce the body weight support, reduce the robotic assistance, patient start walking on the ground with time with conventional training. Advantages, you can do faster progressive, more intensive training, less strain on therapist, adjust the gait pattern also, improve motivation with visual feedback. You can assess what you're doing in day one and reproduce next time sessions. Again, Cochrane review for lower limb have shown that it is more effective than conventional therapy alone. And every 5th person post-stroke could not have walked, can be made to walk if you start this type of training in conjunction with physical therapy. Also very important, this is mainly useful for non-ambulatory stroke patients. Those able to walk don't need training on robotic. Those who can't walk will be helped by training on robotic. The same for upper limb also. The indications are many. Talking only about stroke today. There are some contraindications. People who have enlarged body weight, more than 35, they have fixed contracture, osteoporosis, skin lesions, back cognitive deficits. But remember, even stroke patients with a tracheostomy and a GCS more than 8 can be made to walk in the system. In the case of tilted with no push drop in blood pressure. Side effects are very simple, some nausea, skin abrasions, inflammation, tendon, joint, muscle pain, and posture drop in blood pressure. So our experience in last 2019, 1270 patients, 520 were stroke patients. And take example of a person with, the family came to us at 1 month post-stroke with a scan like this. A bad ICS stenosis, global ACMC infarct at 1 month. The student right-handed, intubated, ventilated, underwent decompressive cranectomy, PEG, TT. They came to us at 4 weeks. At the time the boy was awake, was following simple commands like flicking hand up and down. He has aphasia, dysphagia, TT, PEG, catheter, hemiplegia. They were to sit out of bed. They need conventional comprehensive neuro rehab, mechanism of stroke, secondary prophylaxis, antispasticity medication, botulinum toxin for making people able to do the robotic training, add medications for improving aphasia, fluoroscopy for swallowing, underwent decannulation, USG, PVR. A lot of medical input is required in the acute stage, along with conventional therapy or physical therapy, occupational therapy, swallow therapy, speech language therapy, splinting, bladder bowel retraining. But remember, it's now 4 weeks in inpatient rehab, 2 months post-stroke, with minimal motor recovery. Just barely stand with about 2 people support. In such cases, conventional therapy is not enough. It's something beyond that. Day one, the guy walking on the road, so he just have smiles on his face. He underwent therapy 6 times a day of conventional therapy plus getting on robotic systems for next 6 to 8 weeks time. You can see his growth and progress chart here. Lot of walking, and then went home like this. Over the MRI here. Actually, 2 or 3 years post-stroke, he got to school and college to pursue education. He still has hand weakness, has motor aphasia, can speak small sentences and are able to study also. Another lady who came to 2017 with a bad right MCS stroke. She came to us at 3 months post-stroke and she was told 3 month golden period is over, you can't change now. But again, we can help these patients and they need good treatment in the next first few months. Antispastic medications, antidepressant medication, carrot vitamin D, start conventional training, botulinum toxin for spasticity, entering with the robotic assistance, also upper limb and lower limb. This is an army of power. You can see scores of Barthel index, Fugel-Meyer, and mass. And then she went to an army of spring training. The scores are changing for Barthel, Fugel-Meyer. ART starts coming in, and then training only on the robotic of the hand. Remember, she was doing 2 sessions of robotic every day, plus 4 sessions of cognitive therapy also every day along with that. 6 per day minimum that we do in the center. And then this are discharge. She was able to walk independently, using her hand also. People can still change. Another guy had Apla syndrome, very bad hemorrhagic stroke on left side. This is that discharge. Actually, he drives his own car now. Helped his father in his business as a builder. This is very interesting. Had a left MCS stroke postpartum with EF of 15%. She was told, don't walk. If you walk, you will die. And she came to us about 2 months post-stroke from interior Maharashtra. You can see a bad MCS stroke here. This is a functional MRI of this patient. You can see these marked areas. These are specific supplementary motor areas for hand and ankle function. So with intensive training, we're able to trigger the new part of to take over function. That's how system of robotics help with conventional therapy to make motor deficits better after stroke or brain injury. To summarize, to get plasticity, you need few things. Functional task-specific training, 1,500 steps per day, 1,000 movements upper limb in one session, good repetition, good intensity, active participation, afferent feedback, and motivation. This happens remote neural circuits, and that will got new recovery in such patients. So robotics is one agent for that change for neuroplasticity in patients with stroke. Very simple summary by Yen to have shown that people who are doing robotic systems see the relevant areas lighting up. We've shown one case. This is a good study to the 80 by Yen et al. 2008. They have clearly shown that the supplementary motor area, the relevant areas are picking up function once you're able to get new motor power. If the whole brain turns red, it has negative predictive value. But the relevant areas fire, it means real something is happening in the brain. We published it long back 2008 or 9. People in chronic stroke who are able to walk to some extent, we can increase their walking speed. We can't do much with that. We also published, if you use this technology, many patients, even 2-3 years post-stroke, who were therapy naive, who were non-ambulatory, 1/3 learned to walk, even in such chronic stage. To training comprehensively, teachers passed you well, give them good rehab at least for 6 weeks. It's been coming up in media very well. We have done 2 issues of their primary main concept on technology in rehab and plasticity in rehab. Just to summarize, we all know we can reperfuse the brain in first few hours by IV TPA, alternate place, or to decompensatory craniotomy by our surgical team. Swelling comes down in first few weeks. Brain tries to change itself in first 3 months. That finishes by that 3 months period. That's why we say that 3 months of recovery nahi hota hai. But it's a wrong notion. Do something, if you do very intensive training in first few weeks, you get something new. It doesn't die down in first few months. And that we call it as 6-6-6 concept. These patients in the acute subacute stage, intensive training, a lot of physical therapy, occupational therapy, speech therapy, cognitive retraining, robotics, what is required at least 6 times a day, 6 days a week for 6 weeks. You can do that you get much plasticity for brain to develop in their patients. Summarize again, always remember, we were told initially in our training days, the rehab was compensatory or disability management. We forgot the impairment. We further led to learn non-use. Current focus of rehab is to target the impairment, be it motor, speech, language, sensory, cognitive, swallow, sphincter, to get new function to develop with due course of time. This is our rehab team. Thank you very much. I've taken the opportunity to invite all of you to next IFNR Con. Mark the dates, March 29th, next year, 2025, to be in CMC Ludhiana. We all welcome you there next IFNR Con. Thank you very much.
Sir, thank you very much for the wonderful summarizing all the evidence available for the rehab robotics and stroke rehabilitation, sir.
Thank you.
Next, we have the hot topic on artificial intelligence virtual reality. We have the digital eyes, the digital ears, and every digital monitoring happening all around us. But how does it help us in stroke rehabilitation? We have the expert in VR and artificial intelligence, my teacher, Professor Lakshmi Narasimhan Ranganathan, sir, to deliver his talk on VR and AI in stroke rehabilitation. Over to you, sir.
Can I have the first slide? Good evening, everybody. As you all know, that the virtual reality and AI are the two key areas in rehabilitation arena. May I have the next slide, please? As you know, that when the evolution of storytelling started from radio, description. Next slide, please. As it slowly evolved into imagination and descriptive things, then came drawing, then movies. Next slide. And even after everything, there is something which was lacking, that you are not part of the, you are not immersed into the story. You still, you know, even when you watch, even though your consciousness get involved in the movies, you are not into it. This was filled by this perception gap was filled by, next slide please, by the advent of the VR environment. In VR environment, you can see that you get immersed, you are getting in and you feel, go and really into, like you can see the person hunting in the story. So this VR has revolutionized the neurorepublication by its presence, and it involves the consciousness. Next slide, please. As all of you know, the introceptive and extroceptive are the two major and the extroceptive is further classified into proprioception. Till today, until recently, the introceptive things were not part of virtual reality. I come back to that a little later. Next slide, please. I'm just immersing you into a virtual reality environment. You can feel that. This is a roller coaster. This kind of virtual environment, this is used in the rehabilitation of vertigo also. This kind of roller coaster rides which accommodates, this is every experience except the introceptive stimulation of the GI and other things were lacking in this. Next slide, please. So the various virtual reality the equipments are head-mounted display, omnidirectional treadmills, specialized sound, scanners for gesture-based interactions, body engagement, and haptic inputs and CVS. Next slide, please. There are two kinds, immersive, non-immersive. Next slide. This is where you sit in a chair and you are immersed into an environment of either wildlife, mountains, and all the environment can be interactive. The environment can be, this is the immersive type of one. And the next slide, please. And this is where the non-immersive, where you wear and look at the environment, and there are various different equipments where you look into. Using these virtual goggles, virtual reality goggles, you get a feel of the environment. These two kinds of thing. And the next is the exoskeleton haptic feedback. You can see the haptic devices is owned by the person, and as he moves the haptic feedback, the piano is being played as per the movement of the person who's wearing the exoskeleton. Next slide. So this kind of gloves, the cyber gloves, are also used in the medicine, where you wear the gloves and palpate the patient in one end, and whatever proprioceptive feeling, for example, an enlarged spleen, the other man who's in the other end, the whole thing is transmitted across the network, across the cyber network, and the other person can also feel wearing the cyber gloves, the same proprioceptive feelings of the. So clinical examination in telemedicine, this is another important landmark. Then the omnidirectional treadmill, which will immerse you. You stand on the treadmill, they make your treadmill experience global. You can walk with the omnidirectional in the foothills of Alps, or like going in the trekking in Himalayas. Any of the environment can be made in the omnidirectional treadmill. Next slide. So coming to virtual reality in neurology, it has enormous role, successfully used in the psychomanagement of anxiety and phobias, where you are suddenly stormed into the phobic atmosphere which you are facing, or through graded, controlled, customized exposure therapy compared to cognitive behavioral therapy. Next slide, please. And I'll just talk a couple of examples of one, the rehabilitation gait and balance, another is arm rehabilitation, one in posterior circulation stroke, and the other in the anterior circulation stroke. I'll just briefly touch upon that. Virtual reality in gait and balance, you see the principle is neuroplasticity as motor learning, as our Dr. Abhishek already talked to you about the neuroplasticity. Next slide, please. So the advantage, you can see the popularity of VR is growing. You can see the various kinds of publications. You can see in 2016, it's grown. The skyscrapers have gone long in 2024. Next slide, please. In balance and gait training, next slide. You can see there is any amount of papers. You can see they highlighted that most of the measures in the final assessment are improved in randomized control. These are all randomized control trials using VR-based rehabilitation, home-based as well as tele-rehabilitation, everything. All of them have showed significant improvement. Next slide, please. Next slide. So the VR is complementary to conventional training. It's comparable to conventional training. And home-based VR is superior to conventional training, which has been proven beyond doubt. Next slide. And there are 10 sessions normally recommended for stroke and 14 sessions for PD. Weightlifting, treadmill VR, obstacle negotiation, dual tasking are various protocols used in VR in stroke. Next slide. And in arm rehabilitation, there is game exercising. The principle is again on neuroplasticity and motor learning. Next slide, please. A task-specific interactive game-based virtual reality rehabilitation system for patients with stroke. A usability test, 2 clinical experiments. Next slide. You can see the patient is seated in front and then moves the hand to play the game and achieve this is the thing. And right now, we, along with the IIT Madras, with Dr. Srinivas Chakravarti's lab, we have developed Rangoli, for finger training, the stroke interactive games. There are 5 games which we have developed. One is like shooting the meteors, and one is playing like for pronation and supination training. One for playing like tennis, the ball will come to your forehand and you have to make a snatch, and next time the ball will come to the backhand. So the pronation, supination action can be get trained. This for arm rehabilitation, we have developed 5-6 games which have already proven value, where it was with Dr. Shailaja group in Sri Chitra. They have tried this arm rehabilitation at IIT Madras, which is now we are also using it in our department. Next slide, please. So these are all the various for arm movement and eye-hand coordination games. Next slide, please. So Rehab Masters intervention is effective in patients with chronic stroke. In addition, the randomized control trials in patients with acute and subacute stroke also showed that Rehab Master plus OT elicited greater improvement in both the Fugel-Meyer assessment and Barthel index compared to the OT only group. So the virtual reality, used as the rehabilitation is slightly superior than the conventional OT. Next slide. The virtual mirror, where visual application of the goal-oriented movements counteracts the non-use of hemiparetic stroking. Next slide. You can see the patient is seated in front of the mirror. The modulation of the movement is achieved by combining the two methods, amplifying the movement, amount of movement, the extent of amplification by attracting the direction of movements towards the target position, and accuracy. Both the amplification of movement and the accuracy of movement are targeted. You can see the actual hand movement, and it's slowly helped out by the environment. You can see the range of movement and then exactly take it to the target. Next slide, please. So this amplification of the visual motor feedback of an executed movement may reinforce the desirability of the selected action, where part of the action is by the muscles which the patient has, and the part is by the assisted feedback. So the goal-oriented movement and amplification VR enhances the use of paretic limit in hemiparetic stroke patients. Next slide, please. So advantages is safe environment. Patient enjoys the session. Good compliance, instills confidence, motivated. No physical consequence from errors. Next slide, please. The disadvantages is cost, less availability. Studies in non-immersive, most of them are evidence for VR is immersive. More evidence for the immersive VR. What virtual reality, as I told you, one step forward, as I already told you, is now upgraded to what is called a sonoception technology. Where I told that initially, when the starting slide, I told you that this does not have the interoception. Now, what they have done is low bass sounds, vibrotactile transducers, all these things are now inserted into the VR environment. So when you go into the roller coaster ride, when you're immersed in that, now you'll have nausea, you'll have vomiting, you'll have palpitation, you'll have fear, everything which you feel as when you ride, and all these components will come. So it's exactly stimulates the internal world to the wearer and decide the experience the wearer feels. Sonoception plus VR opens up a new dimension in the psychosomatic experience, and this is going to be the future in advances in the VR. Next slide. Moving on about the second part of my talk, artificial intelligence. As most of you know that AI, what is artificial intelligence? Next slide. The Turing tests all started in 1950 when Turing made an experiment where he was questioning one room, the computer was answering, the other room, the human was answering. He was trying to find out the differences between the human and the machine, and find out can machines think, and the questions which he asked. Unfortunately, he was not able to find out the differences, whether most of the answers were relevant by the machine, and then he cautioned the people that it's going to be dangerous to allow this AI to grow. Today, in fact, the scenario has become even more scary. The younger generation have given almost a sabbatical to their human native intelligence. They don't have to remember numbers. They don't have to remember any place. Visuospatial memory is not necessary. Calculations are not necessary. Languages are not necessary. Translators are available. AI monitors the patients. The AI can give decision making. Everything is done by AI, and I'm really scared that the human intelligence is slowly going to be on the low. Next slide, please. Even though it's scary, provided we use it judiciously, I think we should be able to do things better. Next slide, please. So it has become an integral part of our normal life. The Google Assistant and the Hey Siri and various banks, everything has got artificial intelligence. Next slide, please. And the VKA and the VKA is one where very limited appearances, like the Google Assistant or the Siri, you can take part in even the chess games, which is all only you do. They can't be made to do new task or activity. They are confined to the limited tasks which they are programmed for. The strong AI is the next one. Has the ability to evolve and continue to learn undefined tasks. They keep on learning newer tasks, newer challenges thrown onto these AIs. They will keep learning. Next slide. And it's Mr. Ikawa, please follow this way. Gives an analyzing situation. Even in the talk, converses using artificial intelligence. They understands the language and replies appropriately. The rules of the language, which is akin to the would you like to have coffee, offering coffee, all these things is done by the robot. Now the emotions was not there. Now the humanoids have started adding emotions to the humans. And now, next slide, please. You can see that this is the VA triggered weapon use, which in the famous Rajinikanth movie where he kills thousands and thousands of police. Next slide. And you must have seen that as a robo, it started the concept in the movie that the robo has started strong emotions to the heroine. So the emotion when you start giving emotions to the robos, we don't know really what is going to be. Is it go? So the two kinds of learning, machine learning and deep learning. Next slide, please. Artificial intelligence, machine learning. So initially it all started with deep learning, with machine learning, with AI. Now every child knows ChatGPT. Even that day I just asked, I wanted to give a thanking letter for something. I asked my daughter to grab it. She just said, I'll do it in ChatGPT. So the younger generation started using every kind of this thing. And, I was very surprised that the kind of one of my residents, when I showed him the image and asked him, what is this? He said, just give me a minute, sir. Can you find out what is the abnormality? I gave him in the X-ray. He puts it into an AI, a radiology AI tool, and he says it marks the place where it is abnormal, because it's a artificial neural network fed AI, and it marks, and he says this is the place where the defect is there, showing out to some bilateral basal ganglia calcification, MBBS boy. So I was surprised that the future is going to be. Next slide, please. Next slide, please. So machine learning and deep learning. The machine learning, the algorithms, development of algorithms, groups in data, an automated process for information processing at multiple levels before giving the output. Data mining for knowledge extraction, whereas in deep learning it is similar to human thought process. Next slide. In human thought process, as you know, yes, no, or PO. The PO is the neither yes or no, and the entire spectrum of closer to yes, closer to no. So in human thought process, it is just not yes and no. As binary in computer, it can be yes, no, neither yes nor no in the middle, and more towards yes, more towards no. How much more towards yes, how much more towards no. All this entire spectrum is in the. So the machine learning types are supervised learning, unsupervised learning, and reinforcement learning. Next slide, please. So, for example, machine learning is this an oligodendroglioma or an astrocytoma? Classification algorithm, tumor in the image, 85% certainty. The tumor in the image is astrocytoma, only 15% certainty. You must have seen even the survival chances is predicted by computing various prognosticating factors until the chance of survival of this gentleman is 15%. The chance of survival is 45%. When you allow the robot to make the decisions, it may say that 15% is not worth reviving the patient. But I don't know. These are all scary situations of future. Next slide, please. So, for example, when the patient is seen by a neurologist in the OPD, he sees the patient and then makes a diagnosis, initiate treatment. There is a hidden academic layer, so many years of experience with the exposure to so many thousand patient years, heuristics, pattern recognition, and empirical. All these things are hidden in our deep learning. What outsider sees is only a prescription and a diagnosis. Next slide, please. But the processing happens within the brain, and that is the hidden layer. Next slide. Next slide, please. So this is what it says. The input is there, output is there. There are a lot of processing which happen in our brain. And this to say that same things in the deep learning, which mimics the human intelligence, giving weightage to each and every factor, higher weightage for, say, for example, calcification is a factor which gives a higher intelligence in oligodendrocytoma. For example, in mass effect, these are all various factors which are given different wavelengths, and then computers and tell what is this possibility. Probably it is more in favor of oligodendroglioma. Next slide, please. So this is exact. In coming to stroke, next slide. So automation and decision support. Now You know that AA Rapid, which all of you must have been using, even experienced stroke clinicians rarely feel comfortable interpreting all imaging data. The time pressure. Next slide, please. Training models have now come. There is automation. You see, this is the CT. A pixel by pixel analysis is done by the, and then it always gives what is the ischemic core, what is the penumbra. Everything is calculated and given by AI. Next slide. The automated E aspects, and it's not only that, it also says that the stroke suit is there, which calculates what is the aspect score of this patient. 132 scans were non-inferior, comparable to expert readers is absolutely comparable. In fact, it is superior when the aspect score is done by inexperienced beginner. So in the early stage people, the AI is superior to learners, beginners, and then, but it is comparable to the senior people. Next slide, please. So in the beginner with the minimal experience, without automation. Next slide. So it is superior. The decision making, a fully automated decision process for the management of stroke. Next slide. So next slide, please. Look at this. Human intelligence, imaging interpretation using a multimodal non-contrast CT, angio, CT perfusion, clinical assessment based on age, NHS, risk factor identification, frail examination, patient history. AI gives automation for non-contrast CT analysis, DESN aspect score, CT angiography, plot detection is done, collateral assessment is done, CT perfusion by using novel post-processing processes, makes severity in identification markers with adverse events, tissue outcome prediction, patient outcome prediction, and then gives a treatment recommendation adverse. So it enables the decision making by humans aided by AI is definitely distinctly going to be superior. Next slide. So in rehabilitation, if you come, the sensory, the most brain-computer interface, the BA is useful in patients' disability. Brain-computer interface, what it does is takes up the next slide. The various signals from the brain, the EEG signals, fMRI and NARS signal is acquired and then processed, decoded, amplified, and then pattern analysis and control matching, which are used in the either in the rehabilitative BCI or communicative BCI, assistive BCI. Next slide. So the signals which are used can be a slow cortical potential or SSCP or a sensory motor rhythms or P300 or visual evoked potential. Any one of these signals can be used and they are amplified. Next slide. Communicative BCI useful in patients' loss of motor and communicative function, including speech in the brainstem stroke with locked-in syndrome. The output of the decoded cortical signal is transferred to the communication applications. It is used to control the cursor on the computer interface with a click and appropriate icons to produce appropriate commands. You know, you must have seen the eye movements also produce communications. The eye, based on the eye movement, you know, it's exactly what is, you know, locked-in syndrome patient communicates with the just movement of the eyes. This is exactly using a similar one, but only thing is this: the responses are verbalized, and then that gives a biofeedback to the patient. Next slide. A rehabilitative concept of cortical network organization following a vascular event based on the fact that neuroplasticity and this network reorganization results in reduced excitatory firing on the site. So, on attempting to control a prosthetic device, BCI is attached to the paralyzed limb, results in reorganization of the network. Next slide. Next slide. I just finish off with the sensory substitution devices. By serendipity, it was found out that when the visual input was fed to from the optic nerve, was given to the spiral ganglion, they homed to the occipital cortex and the signals were decoded. So they realized that the cables which carry they are not modality specific. They can carry the sensory cables. Optic nerve can carry visual impulses, not only visual impulses, can auditory also. Similarly, the tactile impulses, when given with visual impulses by neural network, they home to the occipital cortex. So this opened up the new arena. Next slide, please. New arena of sensory substitution devices. We all knew that the braille words were in the congenitally blind. When by tactile things they were able to read, they were able to decode. The same thing. We realized that the same thing is magnified in the sensory substitution devices. Next slide. And even the braille, the same areas. fMRI showed that when patient reads with braille, the same area with was the highlight. The fMRI got highlighted when they were reading with their own eyes. So invasive or non-invasive sensory substitution devices, retinal processes are invasive for the rest of the visual system. For example, in retinitis pigmentosa, the invasive sensory substitution devices took the retinal camera and then introduced beyond the ganglion cell layer. That is the famous spectacles, which are now organ flow, which is available for FDA-approved goggles for retinitis pigmentosa. Next slide, please. So this, by using sensory substitution devices, useful obstacle avoidance, motion detection, reaching, objective, all these things can be done. Next slide, please. So combining the processes and SSD is going to be the future. The image is grabbed, when it's made the visual to neural, visual to auditory, visual to tactile, anywhere to any other substitution areas it can be fed, and this is going to be the future. Conscious, last slide, please. Conscious intelligence. When you presently the AI doesn't have the consciousness. Next slide. When you infuse lacks consciousness, the current scenario, we're not able to define understanding consciousness. A lot of works are being done on digitalizing the consciousness. Next slide. What happens when we incorporate consciousness? We have ethical issues. I don't know. And even incorporating emotions has resulted in humanoids getting married. The first humanoid in Japan, the Nova, the girl got married to another humanoid, and I don't know. They are now looking at genitalia in the humanoids, where with the DNA sharing. I really don't know where we are heading to. Thank you for your attention.
Thank you very much for the wonderful talk on virtual reality and artificial intelligence, sir, extensively summarizing the importance in stroke rehabilitation. Next, coming to the most important hindrance that we face in stroke rehabilitation, the pain. So to identify the causes and to provide us with the solutions, we have the expert in pain management, Dr. Navita Vyas, ma'am. Over to you for the pain management in stroke, causes and solutions.
Thank you so much, Guhan, for the kind introduction. And without wasting time, I would be speaking about pain management in stroke. So my presentation would be about the introduction, the causes, the post-stroke shoulder pain, management of degenerative conditions, and then conclusion. So to begin with, pain after stroke is a common clinical problem that is both underdiagnosed and undertreated. Around 70% of the affected patients, they experience pain on a daily basis. And what happens if they are not treated? The pain is not treated, and there's a cognitive decline, there's a functional decline, leads to fatigue, depression, so much so that they have a suicidal thoughts and tendency. And this overall reduces the quality of life of the patient. So we'll be talking about one by one in detail. Post-stroke shoulder pain. This is the most common medical complication of stroke and very distressing complication after stroke. The prevalence is somewhat from 34 to 84%, and onset can be as early as 2 weeks to 2 to 3 months. It has a multifactorial etiology. It can be central cause. There can be peripheral cause, which is the musculoskeletal etiologies, which can be adhesive capsulitis, subluxation, because the tone is, there's a hypotonia, and there's a the arm hangs around, and that causes a subluxation, leading to rotator cuff pathologies. 1/3 of them, they have multiple contributing factors. How should we go about it? There's a multimodal approach, but there's a lack of evidence what to do when. So that's a challenge in managing shoulder pain after the stroke. Coming to positioning, there's a supporting evidence of positioning of the arm, but slings and strapping, we don't know whether they help or not. But once they develop some pain, they would definitely help. This kind of the shoulder brace, it helps in reducing the pain. Prevention, joint prevention strategies should be used. We should tell our therapist, please do not use overhead pulleys, because that can lead to rotator cuff tears. What should be the position of arm while doing the therapy? In the acute stage, the arm should not move beyond 90 degrees in flexion and abduction. And if we see that the scapula is also moving is upwardly rotated, then and the humerus is laterally rotated, then only go ahead and do the overhead abduction. So this should be taught to the patient and the therapist and the staff who are taking care of our patients. There is some role of functional electrical stimulation and TENS in the supraspinatus and the deltoid muscles, most commonly treated. It has shown there is some improvement in the pain, and also some implantable systems are available. Injections, intra-articular corticosteroids have been used for these musculoskeletal conditions, which shows some more or less some improvement. Botulinum toxin injections intramuscular with conservative management, it helps in reducing and not the pain, but they help in improving the range of motion and thus help in the functional rehabilitation. Braun et al., they also thought of doing the surgery and resected the tendons of subscapularis and pectoralis, and they found out after the surgery intensive physical therapy program was done in the post-operative period, which helps in reducing the pain and improving the range of movement in the patients with the post-stroke pain. But again, after 6 months, the patient experienced pain and discomfort. So this is a promising intervention, minimally invasive interventions, which can be done in patients with post-stroke shoulder pain, which is suprascapular nerve block. The efficacy and safety has been established in rheumatoid arthritis and degenerative conditions of shoulder. But this was a study done by Wakeling et al., which was an RCT which compared suprascapular nerve block with placebo, and they found out that there was a statistically significant reduction in pain after doing the suprascapular nerve block, and the number needed to treat to reduce one stroke survivor pain by 50% at 4 weeks was 4, which is very good number. So this is how we do with ultrasound guided suprascapular nerve block. We identify the suprascapular notch, and we can see this needle coming in plane approach, and that helps in reducing the pain. So we had this patient who had severe pain and which was hampering his rehabilitation, and after doing the suprascapular nerve block, immediately after that, pain full range is attainable, and the patient's movement, the participation in the rehab, it improves significantly. We can also do PRP injections if there is a muscle tear. If we do a diagnostic ultrasound, if we find some tear or tendinopathy, then we can use platelet-rich plasma in the tear. Here we can see that there's a full thickness tear of the supraspinatus where we did the PRP. The patient improved, the range improved, and the pain reduced. And we can see when after 6 months, when we did for the same patient the ultrasound, we could see some muscle fibers growing. So there's a regeneration with the PRP. So we are helping not only in reducing the pain, but also treating the cause, treating the tear in the muscle. So what is the evidence? If you look at the evidence, so prolonged positioning does not negatively influence the range of motion, has a level 1B evidence. Slings may prevent subluxation, limited evidence. Strapping of the hemiplegic shoulder, again, there's a conflicting evidence. Gentle exercises, physical therapy, level 1B, so it's a moderate evidence. Electrical stimulation reduces pain, again, a conflicting evidence. Steroid injection do not improve the pain and range, has level 1B. So corticosteroid injection into the joint has no role. Botulinum toxin reduces the pain, has a limited evidence in pain, but improves the functional rehabilitation. Suprascapular nerve block has a promising role because the number needed to treat is at 4 weeks is 4. Coming to the next cause of the pain is a complex regional pain syndrome, which is again the patient complains of continuing pain, which is disproportionate to the inciting event, and is one of the symptoms present within the form of sensory, motor. So they have hyperesthesia, allodynia, skin color change, pseudoedema, and also some motor or trophic changes. The incidence of CRPS ranges vastly from 2 to 49%, and this has been seen. Personal experience says that if the post-stroke shoulder pain is not treated in time, then they definitely go to complex regional pain syndrome, that is the shoulder hand syndrome. So the mechanism, not going into the detail, there's a peripheral sensitization leading to central sensitization, and there's a crosstalk between the sympathetics also. So that causes sympathetically maintained pain in CRPS. Though it is a diagnosis of it's mainly the clinical diagnosis or diagnosis of exclusion, but radiological images, it helps. Triple phase bone scan helps in supporting the evidence. DEXA scan, because there's a osteoporosis, thermography can help, and this sympathetic ganglion block, it can be a diagnostic as well as therapeutic intervention. How do we manage CRPS? The aim is to alleviate the pain and restore the function by 4 cornerstone of treatment using pharmacological interventions, physical therapy, and psychological interventions in the form of cognitive behavioral therapy. What are the pharmacological agents which can be used? It's a WHO step ladder pattern in which we start with paracetamol, NSAIDs, and then go to weaker opioids like tramadol and tapentadol, and then if they don't respond, then go to stronger opioids. In India, it's better not to use stronger opioids because they have so many comorbidities, and the stroke is already there's a brain insult happening. So using opioids, stronger opioids, it has to be used in a very, very controlled manner. So rather than doing that, we can go directly to the interventions. What is the evidence? Paracetamol has no evidence. NSAIDs has insufficient evidence in alleviation of the pain. So the recommendation is that go according to the step ladder, WHO step ladder pattern. Now coming to the calcitonin, because they have osteoporosis, so it has a conflicting evidence. Bisphosphonates, again, IV palmitonet and oral alendronate have been used, and it has been shown to decrease the inflammatory signs. But again, we don't know what are the guidelines for doses, what should be the right dose, and for how long they should be given. Same is the case with steroids. A pulse dose, it helps in a very good manner in reducing the pain and the inflammation, but again, we don't know how long and when to give it. Anti-epileptics, the gabapentinoids, the gabapentin has been studied, and it suggests that it reduces the pain, but the sensory signs, it doesn't improve in that. There are no studies on pregabalin and carbamazepine and TCA. The study suggests that there is no role of tricyclic antidepressants, but the personal experience says that we can use both and gabapentin and PCAs for reducing the pain. In refractory pain, non-refractory, the pain which is not getting better by oral pharmacological agents, we can use IV ketamine in the dose of 2 to 3 milligram per kg infusion in half an hour. It has a level 2 evidence, and it helps in non-refractory pain. The interventions which can be done for a CRPS is sympathetic blocks like stellate ganglion block, spinal cord stimulation, RTMS, mirror therapy, physical modalities, and physical therapy. So RTMS, it can be used on the contralateral motor cortex. It alleviates the pain in CRPS. What is the mole of how does it react? How does it act? It acts on the NMDA receptor as an NMDA receptor antagonist, and thus reduces causes the central desensitization. Mirror therapy, it helps in restoring the relationship between the motor intention, peripheral sensory input, and the visual input, and thus helps in reducing the pain. Stellate ganglion block, as I already said, that it can be used as a diagnostic as well as a therapeutic approach. So if we give a local, if we inject around the stellate ganglion, which is at the level of C6 or C7, that's the carotid artery. So that's the injected, which is spreading along the prevertebral fascia. So that helps us to identify that yes, that we have targeted at the right point, and also reduces the pain. So this was a gentleman who had CRPS, and we can see when he makes a fist, he's not able to do that, and he was left-handed, so his ADL was hampered. He was not able to do fine motor activities in spite of having the function. But after doing the stellate ganglion block, he's able to make the full fist and was able to use his hand for the ADL and the fine motor activities. If you see the shoulder range also, the overhead abduction was not possible, but just after the injection, we can see the range of motion in the shoulder is also reduced, and the swelling has also reduced. So all the signs and symptoms for the motor, the sensory, the edema, pseudomotor, they can be taken care of with sympathetic block, the stellate ganglion block. Now, what are the recommendation and what are the evidence? So stellate ganglion block in CRPS, there's a positive recommendation with 2B plus evidence. Spinal cord stimulation, though not very common in India, but it has a positive recommendation with 2B plus evidence. Brachial plexus and epidural infusions, peripheral blocks, they can be considered. RTMS has a strong evidence of pain relief. Mirror therapy has a moderate evidence for decreasing the pain. Traditional physical therapy and occupational therapy has a limited evidence for positive results, but it has been recommended as a standard part of the treatment. Coming to the third cause of the pain is a central post-stroke pain, which is centralized neuropathic associated with sensory abnormalities, particularly of thermal sensation in the painful body part. So they always complain that there's a burning in the whole left, either left upper limb or the whole left side of the body, and or sometimes they say it's very thanda or cold. So incidence is around 8%, and usually they are lost to follow up because they don't, if they come for follow up, or if they are not from the same city, then they go to other doctors and they are not able to realize that this is the central post-stroke pain, because it starts, the onset is after 6 months to 6 years. Anyway, between this, so it's a long time. It's a late complication of stroke. How do they always say what are the clinical features? They always use a verbal descriptors like the pain is aching, burning, freezing, squeezing, lacerating. They have pain and then it goes away. It comes and goes. There's allodynia. The pain quality is variable. Abnormal sensitivity, raised threshold for perception of touch and 2-point discrimination. The first line management is amitriptyline and lamotrigine. Second line is mexiletine and fluoxamine. And on those who do not respond with this, then RTMS and deep brain stimulation can be used, and behavioral therapies and physical therapy, they are a part and parcel of any management of stroke. Coming to the post-stroke headaches, usually they constitute about 10% of the patients. It starts at 6 months, and when there's an onset, headache at stroke onset, definitely they have headache at 6 months post-stroke. Usually it is tension type of headache, and that has a pressing quality. Mainly because of the trigeminal system involvement, the medication uses dipyridamole. Then we have to treat the coexisting degenerative diseases, which can be in the form of cervical pain, lumbar, hip pain, knee pain, any arthritis, or which precipitates due to immobility in the acute and subacute phase. And there can be facetal myofascial pain radiculitis, which are managed by conservative management in the form of safe analgesia. NSAIDs should not be used, and physical therapy. But interventions in the form of nerve blocks, myofascial blocks, or PRPs into the joint, they should be done early in the management rather than waiting for a long period of time, because rehab is very important. We are losing time in the rehab. So this was a gentleman who we can see had stroke and is not able to bear weight on the knee because of the knee pain. So then we did a ultrasound guided PRP injection for the same, and we can see that after the injection he's walking and putting full weight on the affected knee. And we can also see that there is a significant improvement in the X-rays. So there is no space here, but after 3 months after the PRP, we can see some space which is developing or regenerating. So if we do an MRI, that could have been a better one, but in X-ray, if it is showing, it's a significant improvement. So to conclude, there can be the peripheral causes like muscle tone, a loss of muscle tone, local inflammation, which is treated by OTPT, steroids, edema control, suprascapular nerve block. If not getting better, they can lead to autonomic and central sensitization, and that can be, if there's an autonomic change, that can be treated by sympathetic blocks. Central sensitization again can be treated with pharmacotherapy, OTPT, RTMS, mirror therapy. All this leads to psychological depression and anxiety and stress to the response to pain, which should be dealt with cognitive behavioral therapy, and also the comorbid or the existing psychiatric illnesses should also be dealt with. So to conclude, managing degenerative conditions in stroke is needed. Early identification and management of shoulder pain is important for improving the participation. Early diagnosis of central post-stroke pain is the mainstay. Promising role of interventions and proper RCT should be needed for stroke post-stroke pain, because we need to know the causes and the management for improving the rehab and improving the quality of life with patients of stroke. Thank you so much, and I would be happy to answer any questions.
Thank you. Thank you very much for the wonderful talk on the causes and solutions for the post-stroke shoulder pain, ma'am. And any one of you here would like to get their hands on for ultrasound-guided pain interventions can contact ma'am to learn more about it further as well.
Sure.
For the next topic, that's post-stroke swallowing dysphagia. We have the expert in swallowing, Dr. Zainab Nagri, for management of post-stroke dysphagia. Over to you, ma'am.
Thank you, Doctor, for such a warm welcome. And I would like to thank IFNR and INA for giving me this opportunity to talk on post-stroke dysphagia, which is a topic that's very close to my heart. Can you see the slideshow mode now?
Yes, ma'am.
Okay, so I shall go ahead. So as we know, the strokes are the second leading cause of death worldwide and the third leading cause of disabilities. The stroke causes a lot of impact on the physical, the language, the speech, the dysphagia, and the cognitive component, but it also creates a havoc with dysphagia, which we know has a direct impact on the quality of life, not only of the patient, but also of the family members. Just 1 second, I'm not able to move my slides. Sorry. So Tanner defines stroke as an impairment of the emotional, cognitive, sensory, and the motor acts involved with transferring a substance from mouth to stomach, which results in failure of nutrition, hydration, posing a risk of aspiration and choking. I particularly like this definition because it covers not only the physical aspects that are involved with swallowing, but also the cognitive and the emotional. Now, the incidence of stroke in the population ranges from as low as 19% to as high as 81%, making it very necessary for the need of rehabilitation. Stroke will have a number of complications such as malnutrition, dehydration, aspiration. All of this will result in a decreased quality of life of the individual and pose an adverse impact on the mental health of the individual. Now, dysphagia due to stroke can impact all the 4 stages of swallowing, but as a therapist, we primarily look at the oral preparatory phase, oral pharyngeal, and the pharyngeal phase. The role with the esophageal phase is still emerging. Now, what are the common signs and symptoms that we will see in a patient post-stroke dysphagia in the oral phase? You will see a lot of poor oral secretion management. They'll have a lot of pooling of saliva in their mouth. The patient will be drooling on the bedside. The patient will require a lot of effort and time for mastication. Often while they're chewing, there'll be a lot of residue or stasis in the mouth. Sometimes there can be an anterior loss of the bolus in the, you will see the food drooling down. Or sometimes the patient may also find it very difficult to transfer the food to trigger the swallow. This may even result in spillage of the food. That means the food will enter into the pharyngeal space without the patient being prepared to swallow. All of this together will result in a prolonged meal time. The symptoms of pharyngeal dysphagia that one typically sees would be an incomplete swallow or a delay in the trigger, an uncoordinated swallow. That means when the patient is trying to swallow, the laryngeal inlet will still be open. The patient may also experience a nasal regurgitation. There may be residue. The patient may have a wet voice that will result in a coughing or choking episodes. And sometimes the aspiration could be very silent, where you will only see clinical features like watering of the eyes or fever spikes. Now, what is the difference between the dysphagia that we see typically post-stroke versus those that we see in neurodegenerative condition? The onset of this dysphagia is acute. It responds very well to therapy. So the patient should improve with therapy, and the prognosis can be varied depending on the site of lesion. So many or most of the patients will have very good prognosis, with a few having guarded prognosis. The goal here is to move the patient from an RT or a PEG to complete oral feeding. And the treatment approach that one will use will be very, very active. So as Dr. Abhishek mentioned, that the more active and more intensive the approach, that would be better for these patients. Of course, keeping in mind the airway safety. We'll be periodically assessing this patient to assess the improvement and not really the decline, as you would have in neurodegenerative conditions. And the patients and their family members would be very satisfied with the treatment, and the burden on the family would decrease with time. So how does one start working with these patients? So the first premise would be the dysphagia evaluation, where most of us clinicians would like to use a three-pronged approach. The first would be a medical chart review, followed with a bedside clinical swallow evaluation, and then now with the with the advantage of technology, instrumental assessment is also pretty much mandatory. All of these three together will put the complete pieces of the dysphagia, or how it's happening, or what structures are really involved, and will give us a clearer picture. So in the clinical swallow evaluation, literature has many scales mentioned, like this is the ASHA scale, which is like a proforma that is there. You will have the NOMS, which is the admission patient reported scales. You will have EAT-10. You will have the GUS, you will have the functional oral intake scale, you will have the MASA, which is the Man Assessment Scale of Swallowing Evaluation. So it's very important for each of us to design our own proformas and see which swallowing scale would be important for our clinical practice and try and put that together. It's also very, very important to look at the quality of life impact in swallowing. As we know, being Indians, food is such an integral part of our daily living. The next step would be instrumental evaluation. Few years ago, this was complementary or not always necessary, but now I would say that in most setups, all of us think that this is mandatory, because what this does is gives us much more of a clearer understanding. It moves our mindset not only from aspiration or no aspiration, but helps us understand what is the bolus flow outcome, which muscles are impacted, and how we must design our therapy regime. So the two popular instrumental evaluations would be the VFSS and the FEAS. The VFSS would be a fluoroscopic assessment of the swallowing. It's a real-time assessment wherein you are giving food along with barium and observing what's happening and how. You're able to detect very trace aspiration as well. However, this involves the radiation exposure and collaborating with your radiology colleagues. You can't give large amount of boluses, and you have to make sure you are quick with small samples of boluses in order to limit the radiation exposure. FEAS is the fiber optic endoscopic evaluation of swallow, wherein you pass a thin scope through the nasopharyngeal space and you are observing the swallow indirectly. So you're not looking at the oral phase and the actual phase of swallow, but you're looking at the status of swallow before and after the swallow is complete. Here, the advantage is you get to look at the anatomy very, very clearly. However, sometimes you may miss trace aspiration, especially the ones that would be happening during the phases of swallow. But this is quick, easy, can be done at bedside, and there is no radiation exposure involved. In most setups, the ENTs and the SLPs do this together, or sometimes they can even do it individually. This can also be used as a biofeedback. So once we are done with a comprehensive assessment, then we move on to therapy, where the goals of management would be, first, you want to improve the safety and the efficiency of swallow. While doing this, you want to make sure that you minimize the risk of any pulmonary complications in these patients, and you want to determine the optimum feeding method or technique so as to help the patient to return to safe and efficient oral intake. So the management strategies can be broadly classified as the rehabilitative strategies and the compensatory strategies. The rehabilitative strategies are those techniques that will create an everlasting change in an individual's swallowing, improving the underlying physiological function. In stroke populations, rehabilitation is extremely important because we know that we can take advantage of the neuroplasticity. So some of the rehabilitative techniques that an SLP would use would be oromotor exercises, which would involve the tongue exercises, the tongue resistance exercises. You may also want to use things like the speech gears or the chewy tube or the IOPI device. Then you will want to typically work on the laryngeal elevation by using a high-pitched E, or lifting paper with a straw exercise, or producing the falsetto. After that, you may want to also work with swallowing maneuvers such as Masako, shakers, Mendelssohn's, chin tuck against resistance. Based on your evaluation, you will try and design a therapy plan, including specific maneuvers with each patient. We can also use SEMG to provide biofeedback. So, you can train the patient actually to strengthen the swallow by showing it to them visually. Vital Stim has this as an option. Thermal stimulation using the fascial pillar stimulation or the lemon bolus or the SAR bolus can be used. The ice chip protocol is an is another protocol that is used typically in the ICU setups very popularly. We also have the neuromuscular electrical stimulation. There are several devices that are available in the market. VitalStim or the eSwallow or Myomed are certain popular ones. Now, with more and more literature on expiratory muscle strength training, our initial literature was in Parkinson's group, but now we're seeing a lot of its role even in the stroke population, especially with patients with poor respiratory control or poor airway protection. Apart from these rehabilitative strategies, we will also have a lot of compensatory strategies that we will start using or teaching the patient in order to start initiating little by little certain amount of oral feeding. The first thing we'd like to do is do dietary modifications using the ITSE protocol. ITSE is nothing but the International Dysphagia Diet Standardization, where you have 7 levels of different consistencies. Most stroke patients would be safe on level 4, level 5, and level 3. So you'll start off with that and then gradually build up to the other levels. You may also want to do certain postural changes or strategies such as the chin tuck when there is a delay or a poor oral containment. You may also want to ask the patient to turn their head to the weaker side when there is unilateral pharyngeal paresis. And when there is poor airway protection or there is spillage, you may want to teach the patient chin down with breath hold. So there are a number of combination strategies using the fees you can identify for a particular patient for a particular consistency and start training the patient actively with feeds using these. We will also modify the rate and route of oral intake. So typically with liquids, initially it may be difficult for the patient to directly sip on a glass. So you may want to use a graded straw or a modified spoon, etc. Techniques to enhance the trigger of swallow can also be used. So the most popular technique would be using carbonated beverages for patients with pharyngeal residue or with poor reduced laryngeal, with residue or with poor cricopharyngeal opening. You may also want to chop up food for patients with poor oral phase or chewing difficulties, and you may want to thicken foods for patients with delayed pharyngeal swallow or patients who have an uncoordinated swallow. So based on what is safe for each patient, you can design a meal plan using the recommended consistencies as well as strategies and the rate and route of administration of the food. So, as you can see, for a beginning clinician, there are so many activities and so many strategies. So how does one organize a therapy plan? So based on the impact, you will design a therapy plan in certain broad areas, whether the patient is alert, has good cognitive functioning level, is able to understand commands, is able to clear his throat, is off oxygen, off a ventilator, is able to manage his breathing, how is his breath support, what is the status of the oromotor structures, what is the status of the trigger, how is the patient able to hold the breath or make sure there's airway safety, and finally, whether the swallow is efficient, in the sense if a meal time is taking 2 hours, then it's not really efficient. All of these areas we will look into so as to make the patient ready for oral feeding, and we will design an therapy plan with customized exercises in each of these headings. So to look at this a little better, I'd like to give examples of some clinical cases. So this is the first patient. She's a 70-year-old female who had a left MCA infarct. She had altered level of alertness in the ward. She was able to understand spoken language, and she was unable to understand spoken language and express verbally. So she had an aphasic component. However, she had no gurgle, no wet voice, and there was a palpable hyolaryngeal excursion present, and she had very good oral secretion management. So she was not coughing or spitting or didn't require oral suctioning. So we did a feast for this patient, and as you can see, both her vocal folds are mobile. You don't see any pooling of secretion. Her LARs are present, and she is reacting very well to it. She also has a good whiteout and is able to handle a puree consistency very well. You can see a brisk whiteout, and there is no penetration or aspiration that you will notice in this study. However, since her alertness level was poor and She was not very awake or not responding to commands very well. She had an RT in C2. So in such a patient, we are not working on the swallowing per se, but we are working more on the language component, the cognitive stimulation component to make her ready for oral feeding. So even in patients with global aphasia or Broca's aphasia, sometimes you may need to hold on to swallowing till you develop better alertness in the words. This is one clinical scenario that we will typically see. The next one is of a patient who came to us following a stroke of the brainstem 3 to 4 months ago. The patient was very alert. He was a doctor himself, very communicative, could understand everything. He had a history of COPD. He was with a cuff tracheostomy tube done at the other center and a peg. His speech was very gurgly and dysarthric. So when we did a feast on this patient, you can see that there is a lot of pooling of saliva. There is a lot of aspiration. The patient was eating earlier, so you can see some food lodged. When he tries to swallow, you won't see a very brisk whiteout, and you will see a lot of the food penetrating as well as silently aspirating and residue. So you're not seeing the entire whiteout clearly. And as you can see, there is a lot of secondary aspiration because there is the hyolaryngeal excursion is weak and hence the food is entering through the cricopharynx. Now, this patient is not a candidate for oral feeding, and we need to do intensive swallowing therapy. You would like to work on respiratory exercises. You would want to work on the trigger of swallow with, say, fascial pillar stimulation or the vital stim. You would want to give him swallowing maneuvers to strengthen his hyolaryngeal excursion, teach him supraglottic swallow to protect his airway, and then finally start introducing feeds based on once you feel that his swallow is a little more efficient. So this is his video post some amount of therapy. This is his mid-therapy video. He could still not tolerate liquids, but he was able to tolerate purees in this study. You can see that the gurgle is reduced. You can see there's no pooling of saliva, and you will see a brisk swallow for the purees. The next case scenario, which I would say is one of the most challenging caseload that you would get for any SLP with dealing with dysphagia, is the lateral medullary syndrome, where you will see a triad of a paralysis of the left vocal fold, a weak hyolaryngeal excursion, and maybe even a cricopharyngeal spasm. Now, this patient came to us with very poor oral secretion management. He had a PEG, a TT, and he had a wet and gurgly voice. This was a young gentleman. As soon as you see the scope, you can see the entire supraglottic really squeezed up. You see a lot of secretions sitting there, and you can see he's trying to constantly gurgle it and get it out. You can barely even visualize the vocal folds. We had to do a suction to be able to reach there. You can see a paralyzed left vocal fold, and you can see a lot of the saliva is pooling at the cricopharynx. However, you don't see a strong laryngeal elevation. So before considering Botox or any other treatment modality for the cricopharynx, first you would like to work on swallowing exercises for this patient. So that's exactly what we did. We worked on respiratory exercises, the vital stim, all the swallowing maneuvers, exercises to trigger the laryngeal elevation as well as strengthen the same. And then finally, when we felt that he had a better laryngeal elevation, we repeated the swallow eval using the FSS, and you can see that the laryngeal elevation is there, but you see a cricopharyngeal bar here. This patient was then taken up for Botox for this and then further therapy. This is another challenging patient that came to us who actually had muscular dystrophy, and he got a stroke on table during a gallbladder surgery. He came to us with a PEG and TT, an inflated tracheostomy tube. He could barely tolerate the speaking valve. He had a very breathy, weak voice and nasal twang due to his neurodegenerative condition. Here again, you can see that you have a paretic vocal fold. You see a lot of pooling of saliva. Without anesthesia, we're able to go so close to his laryngeal inlet, which tells us that the sensations are very, very poor. And you can see aspiration of secretions in this patient. His LARs are very weak. On trying the water, you will see penetration and aspiration of this of the consistency. You don't really see any laryngeal elevation or epiglottic inversion. So it is a very open larynx. However, this family was very, very keen to use the quality of life approach for him and at least try and see if there was any consistency that we could give. And to our surprise, we could see that the purees were going down with gravity without aspirating at all. Almost 30 to 40 ml of purees were going down without any signs of penetration and aspiration. So with this patient, along with the therapy that we would do intensive, we also permitted him a little bit of pleasure feeding, considering that you can see that it is very safe even though there is no laryngeal elevation or aspiration. So that's the beauty of having instrumental evaluation in a patient post-stroke, because you can actually tailor make the exercises. With this, I'd like to conclude that dysphagia post-stroke is a very dynamic and challenging condition. Every brain is very unique. We need to take the advantage of neuroplasticity. For every patient, we must have an eclectic and patient-centric management approach using evidence-based exercises to improve the quality of life of individual. Thank you very much.
Thank you very much, ma'am, for the wonderful talk. And we have had excellent sessions on various topics on stroke rehabilitation. And I'd like to request a few words from the chair, esteemed chair, Dr. Deepak Palande, sir. And if any of the panel, delegates have any questions they can post it in the question and answer box session.
Thank you, Rohan. This was a very informative session regarding the stroke rehabilitation, because we saw the various aspects of the pain management, swallowing management, and the robotic management, VR. I think it has given us the audience a lot of information about the latest development in stroke management in the rehabilitation. I think we should go to some of the questions from the audience if they have. Hello, can you hear me?
I think there are no questions are in the chat box.
Can I make a comment?
Yes, sir, please.
I think whatever all these things, the management which we have talked about, the stroke management, for the common people, it is becoming very, what you call, costly with all this latest developments. So how do you manage to transfer it to the common man, all these therapies?
It's for me.
Pardon?
Question is for me, sir.
Yeah.
There are two things, sir. First thing, these high-end technologies are not required for every patient. As I clearly told, rehab robotics for lower limb, upper non-ambulatory patients. Same for the upper limb. So if you see a spectrum of stroke, 1/3 strokes are very mild, 1/3 are moderate, 1/3 are severe. So only the moderate to severe spectrum, those 30-40% of patients will require these type of technologies. Second, a lot of Indian companies are making low-cost devices now for VR, for upper limb, for lower limb, and the cost is actually 1/4 of what we have paid 10-15 years back. So it's coming up, and I do not believe that at least 4 Indian companies now have made lower limb robotic systems. 4 companies from India have made. 4 have made upper limb systems also now. So cost is coming down, and most of the big metros now at least have now 5 to 6 departments with these type of setup. Even government hospitals now buying these technologies with a very low cost affair. Things are changing in next 10 years. We'll have enough Indian material in the market, which will further bring down the cost to help our patients.
Yeah, I think the solution is to get more of this equipment to the government hospitals where it can be covered under the various schemes. I think the government is including some of this treatment in this Jeevan Dai scheme and of the government.
Right now, government has made some packages for rehab, in the Ayushman Bharat. But those are very basic packages in that most of the technologies are not covered. That's the beginning. At least rehab is part of Ayushman Bharat package with a big initiative by Government of India. I hope in next few years, when the government hospitals have more technology with them, they'll be part of system then.
Yeah.
Sir,
I got a
so
comment that the chat is disabled in the Asmita. People can ask questions. Is it true? Just check it.
Hello.
Can people ask questions in the chat box?
Yes, sir. Even
Okay.
in a Q&A section, they can ask.
Yeah.
yes, sir. Since sir, any so since we are running out of time, can we wind up this session?
I had to thank on the behalf of
Yeah.
IFNR and subsection of the IAN. I had to thank IFNR President Dr. Nimal Surya, IAN President Dr. Sangeeta Rawat, Secretary Dr. UMS, given the opportunity. I had to thank our moderator, our chair, all the speakers, and the delegates for this brilliant session. I hope this will help us to understand different components of rehab in a more better way and take things forward to help our patients. Thank you very much.
Thank you.
Thank you very much, sir. Thank you.
Thank you.
Thank
Thank you.